Good day and welcome to today's live Q&A session. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Lisa, please go ahead.
Thank you. Good afternoon, everyone. My name is Lisa Sullivan, and welcome to the first live Q&A session associated with the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management Training Series. The National Nursing Home Training Sessions are geared specifically to the COVID-19 pandemic and allow nursing homes to receive recognition certificates for attending. In an effort to provide participants more options to view these important training sessions, we have moved to an on-demand training format, which can be viewed at the user's convenience, hopefully extending beyond the curriculum's reach. Today marks the first of our bi-weekly hour-long live Q&A sessions, dedicated entirely to interacting with participants, sharing comments, and taking questions. These sessions are intended to supplement the online training topics and provide nursing home personnel with an opportunity to ask questions of the CMS and CDC as they navigate through the pandemic. Thank you for taking the time to be with us here today, and a special thanks goes out to our CDC colleagues for partnering with us on this important training series. The slides from today's call will be available on the QIO program website, and the recording from today's event will also be posted there within a week, so be on the lookout. Next slide, please. With all the changes to the series and offerings, we're going to provide a brief overview of how to locate some of the important resources located within the QIO program website. This slide shows a snapshot of the tabs on the QIO program landing page, which is at qioprogram.org, which may contain many useful reference materials. We will focus on the Nursing Home Training tab, which is the first on the left, and we have it here with a red arrow pointing right to that tab. So when you go to qioprogram.org, you will click on Nursing Home Trainings, and then, next slide please, a drop-down menu will appear. And it's through this Nursing Home Trainings tab that you're going to find information on on-demand trainings, the Training Fundamentals Self-Assessment Tool, the Toolkit on State Actions to Mitigate COVID-19, Frequently Asked Questions, and some additional resources as well. We'll briefly discuss what is contained in this section of the QIO program website so that our audience has information about accessing the valuable resources included within the site. We'll focus this portion of our discussion on the first option in the drop-down menu, which is the on-demand trainings link, and it's circled here in red so you can see which one you should click on. The on-demand trainings link is where one can find everything associated with our training series. The first blue heading is linked to the CMS-CDC Fundamentals of COVID-19 Prevention for Nursing Home Management page, which contains a list of the critical topics with hyperlinks of recorded training sessions, along with registration links for the live Q&A sessions, which is what we're on right now, and in addition, slides and reference documentation from each of the trainings. The comprehensive National Nursing Home Training Series link, the next blue heading on the list, encompasses our intensive fast-track instruction on infection prevention and control. These is tailored to nursing homes located in areas with increasing COVID-19 infection rates. This is a great first step for nursing homes in newly identified hotspot areas to obtain training in a quick and inclusive fashion. Next slide, please. The on-demand trainings link is also where you can find the toolkit on state actions to mitigate COVID-19 prevalence in nursing homes, in addition to frequently asked questions documents that answered a whole lot of questions previously received on some of our trainings. Please be sure to look at those FAQs as they contain guidance that will help with questions ranging from NHSN questions to COVID-19 testing. Next slide, please. Now, if you go to qioprogram.org and you're not sure where to start in your training regimen, please use our interactive training fundamental self-assessment tool to determine where to begin. And again, on that nursing home training drop-down, it's the one that right now has the red box on it, Training Fundamental Self-Assessment. When you click on that, this interactive PDF will appear. And I'm not sure why we're having some feedback. I just, we'll get that fixed. But we'll go ahead and answer the questions, and this will, of the tool, which will help determine the training best suited for your facility. So on the top left corner, after the blue circle starts a list of questions designed to help you and your team strategize about where to commence your training. And this is really designed to help you get started on the journey. We hope this brief tutorial helps you navigate the QIO program website and provides a starting place for those in need of learning best practices for infection control during this time. Next slide, please. It is now my pleasure to introduce some of the featured colleagues on the call today to assist us with answering questions you may have. Today, we are fortunate to have the following CDC colleagues joining us: Dr. Namali Stone, Dr. Kara Jacobs-Slivka, our previous speaker from the August 20th Cohorting Strategies training session, Deb Smith of HQI, our fellow CMS SMEs, which is Amy Kazel, Sheila Hands, Kathleen Lawrence, and CORE's Angel Davis, Marianne Butcher, and myself, along with a few co-workers from other divisions. We have a whole cadre of people here to answer your questions. So we're going to get started. We received a few pre-call questions via email that we're going to speak to first. And so we thank you for your submissions. We also want our audience to get involved with submitting questions to address while we're here on this live format. So how to do that is go to the bottom of your screen. You'll see a box that says Q&A box, and go ahead and enter any questions you have. And we will start with our first question. Go to the next slide, please. We will attempt to get to all comments and questions that we have at time to address during our event, but we'll answer any of those unanswered post-event. So we'll get started now with the first question that was sent in advance of our presentation today, and I'll go ahead and read it out now. This is, once a resident meets criteria to go on precautions, what is best practice for determining those days? For example, a resident has an appointment on August 26th. Precautions begin when he returns from that appointment the same day and continues for 14 days. Do you count August 26th as day 1 and September 8th as day 14, and resident comes off isolation on September 9th? Or is the best practice to begin isolation when the resident returns on August 26th, but September 9th is the 14th day and resident comes off isolation on the 10th? So I think we're trying to get the date clarified for isolation. And I'm not sure if Namali Stone could answer that one.
Hi, Lisa. Thanks so much, and good afternoon, everyone. It's a pleasure to have the chance to talk with you this afternoon. So the first comment I'd like to make about this question is just about the decisions and some of the considerations being made by facilities when trying to determine placement for residents who intermittently or more regularly have to leave the center for appointments, medical appointments, for example. This issue arises often around how to handle residents who are going out for dialysis on a regular schedule. But this particular question, it looks like, was framed around a single medical appointment on the same day, and then upon return, the decision is made by the center to place that person into sort of the 14-day observation/quarantine process. And I think, you know, with communities experiencing increases in COVID transmission and cases, a lot of concern has arisen about, you know, the introduction of COVID into a center because residents have a higher risk of being exposed when they are outside of the facility. And while that is certainly a possibility. We don't know the contribution that a single appointment, going in and out for a single appointment, or even the contribution that residents who have been regularly leaving the center for dialysis, the contribution those kinds of exposures make to the introduction of COVID into a nursing home compared with the contribution of staff, healthcare workers who are daily going back and forth between work and home, and also potentially experiencing a risk of exposure while they are out in the community. So when our centers are deciding whether to place residents into some form of quarantine, and I think that is really dependent a lot on the prevalence of COVID in the community, the reason that somebody has gone out for an appointment. Was it because of an illness and they were sent to an ER and came back, or was this a standing follow-up visit for something completely chronic and not active? I think we have to make some judgment about the benefit of placing those folks into the quarantine unit to begin with. I know that some centers have been able to create enough space in their building to be able to monitor folks who have gone out for appointments, or to cohort together residents who regularly leave for dialysis into one part of their center, and may choose to place those folks into full precautions. And if you are able to do that and you have the space to do that, we certainly understand it is another strategy for trying to minimize COVID entry. But that may not always need to happen, especially if you feel confident in the transportation and the handling and infection prevention practices that are used for those residents who are traveling out into to receive healthcare and coming back to your center. And when the risk in the community hopefully decreases. So with that backdrop, the question of when do you start counting those days? I think the day that they return can be day one, and then you count forward for 14 days. And on day 14, they can return to their room or out of the quarantine now.
Thank you, Dr. Stone. So our next question is for the CDC as well. So CDC guidelines indicate residents admitted to nursing homes whose COVID status is unknown should be placed in single room, and healthcare providers should wear an N95 or higher level respirator, face mask if a respirator is not available, eye protection, gloves, and gowns when caring for these residents for 14 days after admission. Would this be required for newly admitted residents who have not had COVID but test negative prior to nursing home admission? At what point is it acceptable to move to crisis PPE strategies for this group of residents?
Hi, this is Kara. I'm going to go ahead and try to start working on answering this question. There's a couple of different questions, it sounds like, that are included in this one. I think the first piece was whether a newly, or what process or how should we manage newly admitted residents who have not had COVID, so they don't have a history of having a confirmed positive COVID testing, but have had testing and have actually tested negative. And I think part of the reason that we have described these residents as having an unknown status is essentially we are saying that wherever they're coming from, the hospital or the community, if they're being newly admitted from the community, it's possible that depending on the level of COVID activity in that community, that they could have had an exposure. And so we consider them to have an unknown status, even if they've tested negative at some point prior to their admission, because we worry that there could have been an exposure that could result in them developing infection sometime during that 14 days after they're admitted because of an exposure that happened before the admission. So we would recommend that those newly admitted residents, even if they've had a negative test, are still placed in observation, that they're cared for using the PPE that was described in the question. So wearing an N95 or higher level respirator, or a face mask if a respirator is not available, eye protection, gloves, and gown. I'll pause for a moment and say that so CDC has put out recommendations for nursing homes still fall under the recommendations that CDC has put out for all healthcare settings. And so we describe in a bit more detail in there that if your community is in an area with at least moderate to substantial COVID transmission, that healthcare personnel should be wearing eye protection uniformly or at all times. So I just want to add that piece in there. But we would recommend that they wear that PPE. And for the 14 days that they're in observation. And as I think Dr. Stone had mentioned, testing could be considered at the end of that period. But the second piece of the question was about crisis PPE strategies. And I think this is it's a really important question, because we know, as we've seen over the past few months, that there have been some struggles with PPE supply and concerns about where PPE supply will be at in the future. And so the important thing with these residents who are under observation, when we're thinking about crisis strategies for PPE use, is that there are certain strategies, and I'm specifically referencing gowns here, that we might practice in units, such as a dedicated COVID unit, where you might consider extending the use of gowns, using them for more than one resident. But that is a crisis strategy and really only should be used in situations where you know that those residents have the same infectious pathogen. And again, it's a last resort that we ideally don't want to have to be at. In the observation unit, we don't know if those residents at that point are infected and not showing symptoms. There may be some who never go on to develop infection. So we really do not recommend that specific crisis strategy in that unit. Thank you.
Great, thank you, Cara. This next one is probably going to be for CDC as well. What device would be used in nursing homes for testing, such as Abbott, Sophia machines, etc.?
Hi, this is Namali. So when it comes to the different COVID diagnostic testing platforms that are available, I think it's most of you may be aware that HHS has an initiative to provide point-of-care antigen testing machines to providers across the country, to nursing homes across the country. And there are sort of two specific machines. One is the Sophia antigen testing platform manufactured by Quidel, and then there is the Veritor system for rapid detection of SARS-CoV-2. That's by Becton Dickinson. And we can send in the chat an announcement that HHS made back in July about those two tests. The Abbott ID Now is also a point of care machine. It is not an antigen testing platform. It's actually an a PCR-based or a platform that's looking for the genetic material of the virus. And some centers may have that on hand, and there are some differences in the way that these platforms work, how they detect the virus, and there are different performance characteristics about these platforms that it's really important for you to be aware of and to know what machine you have available to you, either in-house in your center or through your laboratory partners, so that you know the strengths and limitations of the testing that you're using. And to that end, just today, CDC posted new guidance on considerations for how to use the antigen testing machines, the point of care antigen machines that I just mentioned for nursing homes. And so I'm going to ask if my colleagues can share the link to that new guidance into the chat. Thanks.
Thank you, Dr. Stone. We have a whole bunch of questions in our Q&A box, so thank you for those. Please keep them coming. Several of them are asking about CMS training, so let me go ahead and give an answer to a couple of those questions that I think will be helpful. And one is that CMS training, such as this one, the ones that we had illustrated at the beginning of this call on the QIO program website.org, is not associated with the Provider Relief Funds. For more information on the Provider Relief Funds, please go to hhs.gov. A press release was released today, August 27th, which gives you a lot more information on how that is being handled, and that's how to get those questions.
Okay, thank you, Lisa. So our next question is, I think this will probably maybe for the CDC as well. As a hospice consultant, I would appreciate any recommendations relative to best practices for hospices attending to patients within the long-term care facilities. Hospice certainly wants to collaborate and coordinate care per appropriate protocols per CMS, CDC, and nursing facilities. So any recommendations would be passed on to our hospice providers in Louisiana and Mississippi. So are there any recommendations for any best practices for hospices attending to patients within the long-term care facilities?
Hey, this is Namali. I'll start and see if others want to also chime in. You know, I definitely appreciate the support and interest that all our different clinical providers are offering, and the importance that they serve and the services that they provide to our residents, which we also want to make sure become more and more accessible as this experience with COVID extends. So, you know, I think with all providers who may be going to different facilities, working with different populations of patients, it's really important to ensure that they're familiar with the best practices for keeping themselves safe out in the community using cloth face covering or face mask, universal source control, social distancing, all of those strategies that keep them protected. They should be very familiar also with the guidance for the PPE and infection prevention practices, hand hygiene, and maintaining clean, disinfected equipment, etc., when delivering care in a healthcare facility or in a nursing home, and working closely with the provider community, with the centers that you are working with, to ensure that you are familiar with their practices, their recommendations in terms of what PPE to wear while in the facility. In addition, sometimes there's more than just cloth face covering or face mask asked while you're in the building. Some centers are including universal eye protection, for example, face shields or goggles, and being comfortable with how you handle, clean and disinfect any of that PPE that might be reusable and that your protocols are in line with those of the centers where you're working. So I think that's probably just the very beginning of the needs for this provider community, and we will look and see if there may be additional guidance directed at consultants, including hospice providers, on our website. Thanks.
Thank you, Dr. Stone. The next question is also about PPE. It reads, for a long-term care facility, would cloth masks with filters be considered appropriate PPE for enhanced contact/droplet precautions?
Hi, this is Kara. Cloth face coverings, even if they have some kind of filter that is being used with them, would still not be considered PPE, and we would not recommend using them in situations where PPE would be the appropriate thing to use. And the reason for that is that they do not have the same level of testing. We don't have the data or information about them that we do about face masks, FDA approved face masks, and N95 respirators. Thanks.
Thanks so much. Our next question is, if we have a COVID-19 positive employee that has worked with patients, then the patients test at at day 4 post-exposure, and then all patients tested negative. Do these folks need to continue to be on quarantine?
Lisa, this is Namali. I wonder if you could read that one just one more time. I want to make sure I have the timeline and the exposure correct before I answer. Thanks.
Sure. Got it. If we have a COVID-19 positive employee who has worked with patients, then the patients tested at the day 4 post-exposure and all patients turned out to be negative. Do they need to continue to be on quarantine?
Yes. There is a window, as you all know, where an individual can be exposed to an incubating COVID before the virus can be detected by tests and before those individuals develop signs and symptoms of illness. And this is one of the most challenging parts of this virus, right? Because we want to be able to use our testing in a way that reassures us and shortens the duration of time between, when we're worried about somebody's exposure and being able to take them out of precautions. And it's a very difficult thing to do because a single test during that incubation window, that 14-day period, only gives you that initial, the snapshot of that person at the moment that you do the test. So if I believe the last exposure to that ill staff person was, 4 days previous, that negative test is reassuring in the moment, but I cannot assume that my resident isn't potentially still incubating and may still manifest COVID infection 3, 4, up to 10 days later, right? Because there's a 14-day window within which we have seen people who can convert to test positive and then either go on or maybe sometimes don't go on to develop symptoms. So this is one of the reasons, frankly, why we don't encourage residents to be tested prior to admission to a center, because that negative test doesn't immediately reassure us that they are not going to be incubating and potentially developing COVID infection later in the course of that 14-day window when they're first arriving. And this is the same premise. So I would continue to closely monitor those residents. I'm glad that the initial evaluation did not reveal infection, but I would consider either you can do repeat testing. However, I would still be in the same situation where I would want to continue monitoring those individuals closely for the full 14 days after, from that last exposure to the ill healthcare worker. And the testing done in the intervals in between day 0 and day 14 are so I can detect anybody who's developing COVID infection as quickly as possible. So the reason that CDC guidance recommends that we do more frequent testing in 3 to 7 day intervals following an exposure, a known exposure to an infected case, is to find individuals who are developing COVID infection as quickly as possible so we can respond to that, move them appropriately into a COVID care area away from the rest of that unit where they were initially exposed. Thanks.
Thank you, Dr. Stone. The next question is regarding PPE. PPE use guidance is inconsistent amongst surveyors. Can you describe the use of shields on admit non-COVID units? We are told that the shields need to be cleaned from room to room. Is this the recommendation, and what is the logic behind it?
Okay, so this is Namali. There are a couple of pieces of information sort of in that question. The first one is, when should we consider adding eye protection, universal eye protection, to in addition to our universal face mask use when caring for residents in a facility whose COVID status is unknown and even presumed negative? There, on our general infection prevention guidance for healthcare facilities, there is language that talks about the addition of eye protection for the care of patients in healthcare facilities that are in communities where there are high rates of COVID infection circulating. And this is kind of twofold in terms of the protection. It can reduce, we know that the eyes are a source of vulnerability for infection transmission and acquisition. So using eye protection, whether it's a face shield or goggles, in addition to a face mask, just adds a little bit more protection to the healthcare staff wearing it. But we've also found that when people wear face shields over their face masks, and this is more so with face shields than, say, goggles, they're less prone to handling their face mask. There's just one more layer, one more barrier, if you will, in front of their face to reduce the amount of adjusting and fidgeting and moving and handling that might happen with face masks, which if a staff person is actually asymptomatically infected, the face mask could be a heavily contaminated piece of equipment. And so we want to minimize handling that and always clean hands if we have to make adjustments to any piece of PPE before we go on to touch anything else. So the decision to add eye protection to the universal source control strategy is at the discretion of a facility, and it is often in the context of having more COVID circulating and being concerned that there may be unrecognized asymptomatic infected individuals in the building. Then the second part of the question is, how do we safely extend the use of the face protection? And generally speaking, the face mask and eye protection, face shields and goggles are not directly contacting residents during care. And so they don't have the same level of risk of spread from one person to the next as we might see with a gown, for example. And we are very clear that when we are caring for people whose COVID status is unknown, we do not share gowns across different residents. We cannot use that extended use strategy. However, for face protection, you can extend the use, meaning I can basically keep my face shield and face mask on without having to go and disinfect and clean it in between resident care activities, as long as I have not handled it in a way that might have contaminated it. For example, if I were handling the environment or doing something and then I might put my hands on my face shield and adjusted it, now I may have actually cross-contaminated my shield, and I should go and disinfect it for my safety as well as potential for anyone else. Mostly it's for my safety to make sure that I haven't accidentally contaminated my equipment. But if there hasn't been a direct handling exposure, nor has there been an exposure to somebody coughing or sneezing directly at me, it can happen sometimes when you're caring for somebody and you're in very close proximity. If there has not been any direct exposure to respiratory droplets, nor has there been any direct contact where I could have inadvertently contaminated that equipment, you don't have to necessarily disinfect in between each person that you're working with. Hopefully that was clear to folks. Please let me know if it needs a little bit additional information.
Thanks, Namali. The next is a scenario with a question, so I will read that. Once a facility has an outbreak in their facility, one resident is symptomatic and tested positive, all residents and staff are to be tested. Will all residents be considered as PUI, and will full PPE be required when caring for all residents in the facility pending test results?
Hi again, it's Namali. So I missed the beginning part of that question, Lisa. I caught that the question is, are all of these folks handled as if they may be exposed and placed in precautions? But can you just give me the beginning of that scenario?
Sure, yes. They were saying once a facility has an outbreak, one resident is symptomatic and tested positive, then all residents and all staff are to be tested. And then they go on to ask, will all residents be considered as PUI, and will full PPE be required while pending test results?
Got it. Thanks. Sorry, guys. I apologize. So it's a really fair question and important one. We recognize that PPE supplies are limited at places. We know that there's a lot of concern about not being able to replenish your supplies, and so the idea of having to do facility-wide precautions while testing results are pending, I can understand why there's a lot of concern about that. The best approach to this is thinking about where we think the exposures for the staff and the residents around the known infected individual might be, and approaching the use of PPE with that in mind. So if I have a large facility and I've got a single confirmed case on one unit, and I have not had too much movement of the staff who work on that unit to other parts of my building, and I think I've got a relatively contained exposure to that resident, I would recommend that we handle that unit as if people are PUIs and pending, some testing to inform how, if there are other cases on that unit and how broadly, and if there are other staff who work on that unit might be infected. So implementing precautions on that unit and somewhat locking down the movement across that unit to other places while this is being evaluated is a way to kind of localize your containment, and then approach the rest of the building based on what you hopefully can detect in terms of, are there any other places in my building that could have been exposed? If the answer is no, then it's reasonable to localize your precautions use into that unit where the affected symptomatic resident is until there's evidence that there's other individuals who have symptoms or exposure on other parts of the building. The most conservative, the most absolute safe way would, of course, be to try to use precautions for everyone, but that may not be realistic, and so we're trying to make the best judgment and safest practice based on risk. And this is where having rapid access to testing becomes so critically important, because the faster you can do testing and find whether there's been other exposure and spread, the faster you can focus your precautions in those highest risk exposed affected areas and minimize having to use PPE in the other ones. But it's hard to do that if the exposure has, if there's a lot of delay, if you will, between when that first case is recognized and when you're able to deploy testing. There's actually a paper that CDC put out a couple of weeks ago that really showed that the faster we are able to deploy facility-wide testing in response to a COVID case, the smaller the total number of people that are identified during that testing.
Thank you so much, Dr. Stone. Our next question is, are there any infection control best practices for meeting the needs of residents who wander when the resident would otherwise be quarantined or isolated. It appears that one or more of the recent nursing home outbreaks in our state have been traced back to residents who wander. Most of these residents have dementia or some other cognitive impairment and are not capable of voluntarily staying put.
This is Namali. I'm going to start, but I would love to hear from my colleagues in the QIO who may be working with centers who have been trying to address this issue just to get other experiences. It is absolutely true that trying to minimize risk when caring for residents with cognitive impairment and exposure to COVID is a very difficult challenge. And we have seen that it is harder to contain the spread of COVID on units like secure memory care units, where you have very mobile individuals who are not able to maintain social distancing or maintain use of cloth face coverings and things that would help reduce the risk of spread. Some of the things that I have heard from centers have included, having frequent one-on-one kind of interaction with the resident of concern to help redirect them as much as possible into their room or to engage them in activities that help kind of keep them occupied and help reduce the frequency by which they may be leaving their room or wanting to walk around. Certainly continual gentle reminding of the importance of using a face covering, if they can tolerate it, is a huge part of just creating barriers to reduce risk a little bit more to the people around and doing what you can to help them stay distanced from others if they do leave the room. And that might also be educating the other staff and residents on that unit to try to help everyone stay safe. But I'm going to stop because I think that this is a very difficult issue, and I wonder if there are other experiences people can share.
Thank you, Dr. Stone. This is Deb Smith from HQI, and we hear this quite frequently from the nursing homes that we're working with. I do know one of the nursing homes that I've talked to has an area like where typically they would have gone to eat, so the dining room, and they have definite areas mapped out on the floor that keeps them socially distanced. And just like you were saying, something that they can do to keep them busy, even if it's sitting at a table, but within eye shot of the caregivers, so that they always know that, where they are and what they're doing at the time. And that frequent contact with them, with their hand hygiene, for instance, and staying away. And then obviously, too, making sure that all the caregivers are using all of the PPE, because there's no way then that you have source control between that resident and the rest of your staff. But it's definitely something that we hear about frequently, too.
Thanks so much, Deb. Appreciate that.
Okay, thank you both so much. So our next question, I'm actually going to pose this question to Lisa to answer. This is around the scenario-based training. So do facilities need to complete QIO training as well as the training on the CMS Quality, Safety, and Education portal? Or does the self-assessment guide you to which training to complete? I thought the targeted QSEP training was required of all nursing facilities.
Thanks, Angel. The CMS training on QSEP is offered in order to help facilities manage the pandemic and to learn things in the training. It's not the same as the training on the QIOprogram.org website that was mentioned at the beginning of this call. And all the trainings are voluntary. Again, our effort at CMS in order to help nursing homes combat this national health emergency. So again, they're all voluntary. We want to give you the tools you need to combat everything at the front lines. Thank you.
Thank you, Lisa. Shifting gears, we've got a couple of questions about outpatient dialysis residents. I'm going to group them together. The first is, it was my understanding that if a resident went out to an appointment or to dialysis and they wore their mask the entire time they were gone, then they didn't have to go into quarantine. Is that correct? And the second part of the question is, how often should nursing facilities be testing outpatient dialysis residents?
Yeah, hi, this is Namali. I appreciate the question, and I do agree. Right now, we have not put specific guidance that recommends placing residents who are going for outpatient dialysis into quarantine, or and we have not specified any routine testing strategies for these residents if they are asymptomatic. And the reason for those has been that there is a potential risk, but not a well-quantified risk of how this population of residents in terms of bringing COVID exposure or introduction into their center because of going to dialysis. And I do agree with the person who wrote the question that when they are using, a cloth-based covering and they're going in a transport with a transport service that knows how to maintain distance, and it's and everyone is wearing appropriate face coverings, and they're working in receiving dialysis in a center that is following all of best practices for infection prevention and control, their exposure should be quite limited. And there is a potential cost to placing folks into kind of prolonged quarantine because they are frequently leaving the center on a weekly basis. Purely for that, they will basically be in a quarantine circumstance for the foreseeable future, and it has a downside. There is an impact, we know, on the emotional and mental health of our residents, and so we really are trying to be thoughtful and careful about making those kinds of recommendations when we don't know just how much risk is really there. I was saying at the beginning of this call that there are some centers who have chosen to create cohorts for their dialysis residents, and basically placing them in one part of their center. And if there's space for that kind of strategy, that seems reasonable to me. But at this point, we have not recommended a regular screening interval for residents based on their having to go in and out for dialysis. I think we would be interested in learning with providers who are using those kinds of strategies to understand if it's really right identifying otherwise unrecognized infection, because I think it's still a question that we need to understand better in order to inform our guidance. Thanks.
And
Thanks,
this is
Dr.
Kara. This is Kara. I just quickly
Go ahead.
wanted to add, one of the things that can sometimes add to confusion is that there are some states that may have some additional recommendations for nursing homes. So make sure that you check in with your state health department. There are some states that may be doing testing or may ask you to do a risk assessment of those residents. So you may just want to reach out and see if there are any additional recommendations outside of CDC specifically in your location. Thanks.
Thank you, Kara. I think we might have time for one more question, so let me go. If a facility has shared employees with the assisted living on the same campus, do both buildings have to move through the phases of reopening together?
So, Namali, there's a really good question. I think strategies around reopening are in evolution, and this is one situation where I would really want our centers to be working closely with their state and local health department staff, as a resource to help inform that process and decide some of those things. Because I suspect that the circumstances are unique in different communities, and frankly, the level of exposure between assisted living residents and nursing home residents might also be different. So there is some added consideration, I think, about the timing of that kind of decision.
Thank you, Dr. Stone. Could we go to the next slide, please? So please join us for the next live Q&A session, which will be held on September 10th from 4 to 5 p.m. Eastern Time. Registration is required, and we've included the link for your convenience in the chat box. So all you need to do is click on that link and register for the next session. In addition, you can go to the QIOprogramwebsite.org and register there as well. Next slide, please. Thank you again for your participation in today's call. We hope you found some value in the topics that were discussed and the questions that were asked. Please take a moment to complete the survey from today's event, which we do use to improve future sessions. And we'll also put that in the chat box, and it will pop up at the end of today's presentation. We hope you have a great day. Thank you so much for joining us.
That concludes today's session. Thank you very much.